Dear student, I am Dr. Prakash Mungli, a professor in biochemistry. I did my MD in biochemistry from 𝗑𝐲𝐫𝐽 Medical College, Manipal University. In this video, I will be explaining you all details about vitamin thiamine, which is also referred as vitamin B1. Thiamine is referred as anurin or anti-Beriberi factor. Now, what are the dietary sources for thiamine? Whole grain foods, meat, poultry, egg, milk and milk products, green leafy vegetables, nuts and seeds, all these are good sources of thiamine. Fat and highly refined sugars do not contain thiamine, and also thiamine is not synthesized in our body. What is the recommended dietary allowance for thiamine? It is 1 to 2 milligrams per day. Coming to absorption of thiamine from the intestine and also transport. Thiamine is absorbed mainly from the jejunum, and there are two processes of absorption for thiamine. One is a passive mechanism, other is the active transport process. Now, when this passive mechanism occurs and when is the active transport mechanism going on? So, the vitamin thiamine is absorbed by a facilitated diffusion mechanism whenever the concentration of thiamine is high in the intestinal lumen and low in the jejunal epithelial cell. So, that means the transport is a concentration gradient driven, and that means it is a facilitated transport mechanism. Whereas, whenever the concentration of thiamine in the lumen of the intestine is lower than when compared to the thiamine content in the enterocyte, at that time active transport mechanism will be going on, and that needs ATPs. How much thiamine is absorbed from the intestine? It's about 5 milligram of thiamine is absorbed through the small intestine. And once it is inside the intestine, so thiamine, it is converted into its active, biologically active form called thiamine pyrophosphate. That means there is phosphorylation of thiamine. Two phosphates are added over thiamine molecule to make thiamine pyrophosphate. Always remember, whenever you come across a term pyrophosphate, that means two phosphates being added over a molecule. Now, only up to 30 milligram of thiamine can be stored in the tissues, and mainly it is stored in the skeletal muscle, although some amount of thiamine can be found in brain, heart, liver and kidneys. How long this thiamine lasts in our blood or in the tissues? So, it is measured in terms of half-life. The half-life of thiamine is 9 to 10 days. That means after 9 to 10 days, it will be excreted out of our body by the kidney. Now, coming to coenzyme functions of thiamine as thiamine pyrophosphate. There are hundreds of enzymes in our metabolic pathways which needs thiamine pyrophosphate as the coenzyme. Now, TPP is required as a coenzyme for the enzymes involved in energy metabolism, nerve and muscle functions. And most importantly, thiamine pyrophosphate dependent reactions are aldehyde transfer reactions. Make sure you remember that. Aldehyde transfer reaction, that's where thiamine pyrophosphate is participating. So, we can divide those aldehyde transfer reactions into two important ones. One is oxidative decarboxylation reactions, other is trans-ketolase reaction. So, we got to remember two things here in aldehyde transfer reaction. One type of reaction is oxidative decarboxylation, other is trans-ketolase reaction. Now, what are the names of enzymes which are involved in oxidative decarboxylation reaction? That is pyruvate dehydrogenase complex, where pyruvate is converted into acetyl-CoA. I am going to show that in the next slide. Alpha ketoglutarate dehydrogenase complex, and branched chain alpha keto acid dehydrogenase complex. Look for this complex name here. Pyruvate dehydrogenase complex, alpha ketoglutarate dehydrogenase complex, branched chain alpha keto acid dehydrogenase complex. And the other type of reaction where TPP is involved is trans-ketolase reaction. Where do you see trans-ketolase reaction? You see it in a metabolic pathway called pentose phosphate pathway, which is also referred as hexose monophosphate shunt or HMP shunt. So in this pathway, there will be generation of ribose 5-phosphate and also there is formation of NADPH. We are going to see that in subsequent slides. Alright, what happens with the TPP acting as a aldehyde transfer reaction? Where, to give you examples, we have pyruvate which is converted into acetyl-CoA. Note that this pyruvate is a 3-carbon molecule, acetyl-CoA is a 2-carbon molecule. So 3-carbon pyruvate is converted into 2-carbon acetyl-CoA upon removal of carbon dioxide. And also in this process, there will be a reduction of NAD into NADH plus H plus molecule. So what happened here? So in this reaction, pyruvate is oxidized into acetyl-CoA while NAD is reduced into NADH plus H plus molecule. And also there will be removal of carbon dioxide. That's why this type of reactions are referred as oxidative decarboxylation reaction. Another example given here is alpha ketoglutarate, which is a 5-carbon molecule, is converting into a 4-carbon succinyl-CoA. In this reaction also, similarly what I have explained with the conversion of pyruvate into acetyl-CoA, there will be removal of carbon dioxide. One of the carbon is removed as carbon dioxide, and also NAD is reduced into NADH plus H plus molecule. Okay, that means NAD is reduced while alpha ketoglutarate is converted into succinyl-CoA. Now, note that conversion of pyruvate into acetyl-CoA, and this acetyl-CoA, it gets into TCA cycle. Acetyl-CoA is a substrate for TCA cycle. And also, in the second reaction that I have explained, alpha ketoglutarate converting into succinyl-CoA. So succinyl-CoA is also part of TCA cycle. That means oxidative decarboxylation reaction which are involving thiamine pyrophosphate are needed in the TCA cycle, where oxidation of acetyl-CoA going on, and in the TCA cycle there is a generation of ATP. It's an energy cycle. That means whenever there is a deficiency of thiamine, so at that time there will be decrease in TCA cycle and hence there will be defect in the energy metabolism. And note that conversion of pyruvate into acetyl-CoA, and this acetyl-CoA is necessary for synthesis of a neurotransmitter called acetylcholine. Alright, so why do you need this acetyl-CoA? Because pyruvate is converted to acetyl-CoA, and this acetyl-CoA is not only necessary for generation of ATPs, it is also necessary for synthesis of acetylcholine. You know, acetylcholine is a neurotransmitter in parasympathetic neurons. It is also, acetyl-CoA is necessary for synthesis of lipids, including the myelin sheath that will be present over myelinated neurons. And this explains the importance of thiamine in functioning of the nervous system. Now let's move on to see causes for thiamine deficiency. Lack of thiamine intake from the diet. Consumption of food containing high level of thiaminase enzyme which will degrade thiamine, which includes like milled rice, raw freshwater fish, raw shellfish and ferns. It will decrease the availability of thiamine. That can lead to thiamine deficiency. Or food high in anti-thiamine factor such as tea, coffee and betel nuts will lead to decreased availability of thiamine in the food. Processed food with high content high sulfite content, because sulfite can destroy thiamine. And alcoholism. Alcoholism is one of the cause for thiamine deficiency, because during alcoholism what happens, like chronic alcoholics, they have low thiamine due to their inadequate dietary intake, and also alcohol impairs the absorption of thiamine, uptake of thiamine from the intestine, and also it will impair storage of thiamine in the body. That means it leads to accelerated destruction of thiamine pyrophosphate, and thereby it decreases thiamine availability and the use of thiamine pyrophosphate in metabolic reaction. So make sure you remember, alcoholism is one of the important cause of thiamine deficiency in humans. Starvation state can also lead to thiamine deficiency, because absence of dietary availability will lead to decreased thiamine levels. And gastric bypass surgery, which is due to restricted dietary intake, where less amount of food is consumed, and that might lead to people going into thiamine deficiency. Parenteral nutrition, where nutrition is given as an extra supplement in the external means, like through using intravenous route rather than the oral route. So where thiamine content in the supplementation is less, might put somebody at thiamine deficiency. Now, increased consumption states may lead person into thiamine deficiency. What are the conditions for increased consumption states? Diets high in carbohydrate or saturated fat intake, where there is increased demand for thiamine pyrophosphate requiring enzymes in metabolizing carbohydrate and saturated fat, may lead to decreased thiamine levels in the tissue. During pregnancy, where there is increased demand at that, so basically there is increased activity going on, so that also leads to thiamine deficiency. Hyperthyroidism, lactation, fever, increased physical exercise, refeeding syndrome. In all these conditions, there is increased metabolic rate, and during this time there is increased need for thiamine, and that causes thiamine deficiency. And other cause for thiamine deficiency is increased depletion of thiamine, like diarrhea, where there is a loss of body fluid. Along with that, basically thiamine is also getting out of the intestine in the feces. Diuretic therapies, peritoneal dialysis, hemodialysis, or hyperemesis gravidarum. In all these conditions, there will be increased depletion of thiamine, because as to give an example, hyperemesis gravidarum, where there is vomiting going on continuously and there is a loss of fluid from the body, and that means absorption of thiamine content from the intestine is kind of impaired. Coming to decreased absorption as the cause of thiamine deficiency. Like if there is any issues with the intestinal absorption, like chronic intestinal diseases, or example for chronic intestinal disease, we have tropical sprue, celiac disease, or it can be diarrhea going on, chronic diarrhea going on for a long time, or it can be like intestinal infestations, bacterial overload, things like that. Alcoholism again, where it impairs the absorption of thiamine. Malnutrition, gastric bypass surgery, malabsorption syndromes like celiac disease, tropical sprue. Folate deficiency decreases the regeneration of thiamine pyrophosphate. That also puts a patient at risk of thiamine deficiency. Coming to what are the thiamine deficiency manifestations? Deficiency of thiamine leads to a disease called Beriberi. Remember the name. What actually is Beriberi? Within weeks of thiamine deficiency, patients develop resting tachycardia. That means increase in the heart rate at the resting condition itself. Or patient may feel weak, and also neurological signs like decrease in deep tendon reflexes. Some people also develop peripheral neuropathy signs. What are the peripheral neuropathy signs? It is a decrease in the sensation to touch, temperature, pressure, vibration sense. These are some of the features of peripheral neuropathy. Now, depending on the nature of the diet and physical activity of a person, beriberi can be divided into two categories. That is, one is wet beriberi and other is dry beriberi. Let's look into wet beriberi signs and symptoms and what kind of people go into wet beriberi. Wet beriberi is commonly seen in people who are physically active and also those who consume excess carbohydrate diet. That means when a person is physically active, so the energy metabolic reactions like conversion of pyruvate into acetyl-CoA done by pyruvate dehydrogenase complex, one of the enzyme that needs thiamine pyrophosphate. We have seen that in the previous slide. And the TCA cycle, which is an energy cycle, right? So where alpha ketoglutarate dehydrogenase complex is necessary. So that also needs thiamine pyrophosphate. So people who are physically active, who does strenuous physical activity, and also when they consume excess carbohydrate diet like predominantly rice, so where pyruvate has to be converted into acetyl-CoA and acetyl-CoA has to go into TCA cycle. So there is increased demand for thiamine at that time. So in these people, so there is they will manifest with wet beriberi. Now what happens? What are the system that is affected in wet beriberi? So the predominantly wet beriberi affect cardiovascular system. Make sure you remember that. Now when in the wet beriberi, so the thiamine deficiency, it causes a peripheral vasodilatation. Deficiency of thiamine, it leads to peripheral vasodilatation and that leads to high output cardiac failure. So basically high cardiac output state, so it leads to salt and water retention, basically activating renin-angiotensin-aldosterone system in the kidneys. And this salt and water retention, it results in fluid overload, and because of the fluid overload, there will be accumulation of water in the dependent parts of the body. Usually if the person is standing for a long period of time, so there will be accumulation of water in around the ankles, which is referred as a dependent area. Or if the person is lying down for a long period of time, so there will be accumulation of water in the backside. So the accumulation of water in the extracellular matrix side, we refer it as edema. So person with wet beriberi, they will show edema. Now along with edema, what are the other signs that you see in wet beriberi? So since high workload is there on the cardiac tissue, which will increase the cardiac output, and that results in tachycardia. Make sure you remember that patient with wet beriberi will show tachycardia, that is increase in the heart rate, accumulation of water in the dependent area called edema, and also there will be 𝗠𝐞𝐝megaly, that means all four chambers of the heart will be enlarged, and that can be seen in the X-ray finding also. In the X-ray, chest X-ray is taken, so we will see a clear 𝗠𝐞𝐝megaly. Okay. So these are some of the signs that you see there. So basically there will be a overuse injury here to the heart, and it can also lead to chest pain. Now there is a special condition in thiamine deficiency called acute fulminant cardiovascular beriberi, which is also called as 𝐒𝐮𝐬𝐫𝐢𝐛𝐞 beriberi. This is a very rare condition where this is a rapid form of wet beriberi. More rapid form of wet beriberi, we simply refer it as acute fulminant cardiovascular beriberi or 𝐒𝐮𝐬𝐫𝐢𝐛𝐞 beriberi. So here there will be injury to the heart and rapid deterioration of the heart muscle. Patient shows a cyanosis of the hands, tachycardia, distended necks, restlessness, anxiety, and so all these signs will be present, but conspicuously in this particular condition, edema may not be present. Usually edema is absent. So as you see here in the figure, So the patient will show pitting edema. Pitting edema means when you press the thumb or dependent part, so you will see a depression, and that clearly show there is accumulation of water in the dependent area. So which is called as pedal edema. Pedal means in the feet. And also compared to figures here, normal heart and enlarged heart. So compare the chambers, size of the heart chambers. There is a 𝗑𝐝𝐽𝐫𝐢𝐵 shown here. So that means all 4 chambers of the heart is enlarged. Coming to dry beriberi. Dry beriberi, it is involving predominantly nervous system. That's why it is termed as dry, because cardiovascular system involvement here is relatively less. So, in which type of people dry beriberi is seen? Dry beriberi is seen in people who take a poor calorie intake. That means a restricted diet or low calorie diet, and also if a person is leading relatively physically inactive life, meaning sedentary life. If the person is leading sedentary life and also following poor calorie intake, diet having poor, low calories, that type of person may go into dry beriberi. So patient shows signs of peripheral neuropathy in this dry beriberi. So what are the signs of peripheral neuropathy here? So symmetrical impairment of sensory, motor and reflex functions are seen in the extremities. That means it will affect sensory part, motor part and reflex functions. Especially this is seen in distal lower limbs, and that happens because of degeneration of myelin in the muscular sheath, and that too without inflammation. So what are the neurological issues that we see here? So patients generally show bilateral and symmetrical impairment of sensory system, usually paranesthesia, burning pain, and motor and reflex functions of the extremities that is seen here. Along with that, patients will show poor memory, irritability, sleep disturbances, muscle cramps, decrease in the vibratory position sense, absent knee and ankle reflexes. Sometimes there can be wasting of the muscles leading to muscle atrophy and foot drop. These are some of the things that we see in dry beriberi. So here in the figure, you can see a difference here. In the dry beriberi, as you see, there is confusion. It is shown inability to speak, wrist drop, great weakness in the muscles, emaciation because of the poor calorie intake. Patient is having poor calorie intake. In the wet beriberi, there can be edema, numbness in the feet, and also there can be a decrease in the muscle mass and all that. So basically wet beriberi, cardiovascular system is involved, where you can see tachycardia, edema, so breathlessness. So that's the cardiovascular system. And the dry beriberi, you will see all neurological issues which is predominating. Coming to a type of beriberi that is seen in alcoholics called Wernicke's encephalopathy combined with Korsakoff psychosis. So other name of Wernicke-Korsakoff syndrome is, it is also referred as wet brain, Korsakoff psychosis. It is also referred as alcoholic encephalopathy, or simply referred as Wernicke's disease. And most importantly, you need to remember this particular disorder is seen only in alcohol abusers. Make sure you remember this. Only alcohol abusers will show Wernicke-Korsakoff syndrome. It's combination of two diseases. It is Wernicke's encephalopathy and Korsakoff psychosis. Okay, what are the key signs that you see here? So the key signs is, you see vision changes, ataxia and impaired memory. Collection of these signs. So the syndrome is combined manifestation of Korsakoff psychosis and Wernicke's encephalopathy. So the Korsakoff psychosis component is, patient will show nystagmus, ophthalmoplegia, cerebellar ataxia and confusion. What is nystagmus? Nystagmus is, it is to and fro movement of the eyeball. We call it as nystagmus. Ophthalmoplegia, where there will be weakness and paralysis or palsies of the eye movement. Patient may also show incoordination of the movement, that is called ataxia. Now, what is the Korsakoff psychosis component here? Korsakoff psychosis component is memory loss, and the memory loss can be anterograde memory loss or retrograde memory loss, and as such memory loss is referred as amnesia. Okay. Along with this amnesia, patient will show a characteristic sign of Korsakoff psychosis called as confabulatory psychosis. What is confabulatory psychosis? Confabulatory psychosis is, it is a spontaneous narrative report of events that never happened to him or her. That means patient is fluently explaining all the things that the patient has never experienced in his or her lifetime. That is what is called as confabulatory psychosis, which is one of the characteristic feature of Wernicke-Korsakoff syndrome. Especially it is a part of Korsakoff psychosis. You got to look for that. Now, what is the treatment for this particular disorder? Infusion of thiamine along with other symptomatic management is done here. Coming to diagnosis of thiamine deficiency. Measurement of blood levels of thiamine can be done, because we will have to see thiamine, the levels of thiamine to see how much and compare that with the normal range. And also we can measure pyruvate, lactate, alpha ketoglutarate and glyoxylate levels. And most importantly, out of all this, most importantly, we need to measure thiamine levels. And also we can do something called as thiamine loading test. And this thiamine loading test is performed only for criteria for a standard proof of deficiency. Like when we say, okay, whether or not thiamine deficiency is there, in order to prove that, we'll have to do what is called as thiamine loading test. What we do here in thiamine loading test? So in thiamine loading test, we are going to measure erythrocyte transketolase activity. Okay, let me write it down. Transketolase, you know transketolase, it is part of pentose phosphate pathway. Okay, this is one of the enzyme that needs thiamine pyrophosphate, and we are going to measure this transketolase activity in red blood cells or erythrocyte. We are going to isolate erythrocyte and measure transketolase activity in that, and see what is the level of activity before and after thiamine loading. That's what is thiamine loading test. So before loading, what is the erythrocyte transketolase activity, and after loading, what is the erythrocyte transketolase activity. So any increase in more than 15% of this transketolase activity after thiamine loading compared to the before loading activity, after loading the thiamine, if there is increase in more than 15% of erythrocyte transketolase activity, it definitely indicates there is a deficiency there. So it's a definitive marker of thiamine deficiency. So that means make sure you remember erythrocyte transketolase activity measurement, it will indicate nutritional status of thiamine. So how do you measure nutritional status of thiamine? It is done by measuring RBC transketolase activity. Okay. So what is the treatment here? So treatment is we need to provide 50 milligram of thiamine intramuscularly until all symptoms have disappeared. And also we can give maintenance dose of thiamine which is 2.5 to 5 milligrams per day orally, unless if the patient has any malabsorption syndrome. Okay, so we have some thiamine antagonists in the food, like we have pyrithiamine, which is a potent antagonist to thiamine, and also we have oxythiamine and 2N-butylthiamine. They are milder antagonists of thiamine. So these are, make sure remember thiamine antagonists. pyrithyamine, oxythyamine, 2-butyl thiamine. So that's about vitamin thiamine. Thank you.